Welcome to The Explainer. Today, we're throwing you right into the deep end. Picture this. You're in the ER. A patient with acute coronary syndrome just got wheeled in. The clock is ticking. Every single second matters. Dr. Collins, you have the floor.
Time is muscle, doctors. For every minute we waste, a piece of that heart muscle dies. Let's move.
Acute coronary syndrome hits your door. First move is always the same. 325 milligrams of aspirin.
And it has to be chewable and non-enteric. Why? So stop that clot from growing. Now,
for the acute phase, your brain needs to scream MONA, morphine, oxygen, nitrates, aspirin.
Once they're stable, you pivot to BASH, beta blockers, ACE inhibitors, statins, heparin. This is how you stop the second attack. Learn MONA, learn BASH, save the heart.
Before we proceed, a mandatory disclaimer. This content is for educational purposes only, particularly for those preparing for medical board examinations. It is not medical advice. In any clinical scenario, you must always consult official local guidelines.
okay, now that we've had the fire drill, let's slow down and really dissect that first protocol, MONA.
That was an intense start, Dr. Collins. Let's go back to that very first step you mentioned, the aspirin. You were so specific. Why does it absolutely have to be chewable and non-enteric?
Great question, Sarah, because the mechanics here are the difference between life and death. An enteric-coated aspirin is designed to bypass the stomach. We don't have that kind of time. When a patient chews a non-enteric aspirin, it starts absorbing immediately, right there in the mouth. That's buccal absorption. It hits the bloodstream in minutes and shuts down thromboxane A2, the signal that tells platelets to clump up. It is, without a doubt, the single most important drug for survival in this scenario.
All right, let's talk about the O in MONA, oxygen. Now, I want everyone to listen very closely, because this is a huge board exam trap and a common real-world mistake. The rule is absolute. You only give supplemental oxygen if the patient's saturation is less than 90%.
I see. So all those times you see a nasal cannula on basically every patient who comes in with chest pain, if their O2 sats are at, say, 94%, you're saying that's actually harmful? Exactly. And this slide shows you precisely why. Giving oxygen to someone who isn't hypoxic, a state called hyperoxia, does two terrible things. It creates damaging free radicals, and critically, it causes the coronary arteries to constrict, which can actually make the ischemia worse. So if they're sitting at 94%, leave the oxygen alone.
So what about the M from morphine? We use it for the pain, right? But we have to be really careful here. The latest data shows morphine can actually delay how the body absorbs other critical antiplatelet drugs like clopidogrel. So the key takeaway is this. It's not an automatic step. It's only for severe pain if the nitrates aren't cutting it.
Perfect. Now let's move on. The patient is through the immediate crisis, they're stabilized and heading up to the hospital ward. This is where we initiate the BASH protocol.
Right? Let's run through that checklist. B is for beta blockers, to reduce the oxygen demand on the tired heart. A is for ACE inhibitors, to prevent cardiac remodeling. S is for statins, to stabilize that dangerous plaque. And H is for heparin, for acute anticoagulation. So if MONA is about stopping the immediate disaster, BASH is all about preventing the next one and starting the recovery.
You've nailed it. And let's just focus on that A for a moment. Cardiac remodeling. This is what we are desperately trying to stop with ACE inhibitors. After a heart attack, the heart can actually change its size and shape trying to compensate for the injury. As the slide says, it can become a big floppy bag, and that's a direct route to heart failure. ACE inhibitors are crucial to prevent that from happening.
Okay, we have covered a ton of ground. Now, we need to lock this protocol into your memory so it becomes automatic, especially when you're under pressure.
So repeat after me. MONA in the door. This is for that acute phase the second they arrive in the ER. BASH for the floor. This is for the stabilized patient on the hospital ward or getting ready for discharge.
Aspirin. Chew. That is your single most important first action.
And oxygen. Few. Only for the few with saturation under 90%. MONA-BASH. Chew. Few. Protocol locked. MONA-BASH. Chew the aspirin and only a few get the oxygen. And now for our question of the day. In your ER, your hospital, your clinical setting, what's the target time for getting that first dose of aspirin into the patient? Is it under 10 minutes? Let us know your hospital's protocol in the comments.
So, now that our patient is stable on MONA-BASH, the next huge decision is looming.
Do we open up that blocked vessel with a stent, or is it time for bypass surgery? Stent or cut? Join us for our next explainer, where we'll dive headfirst into the revascularization decision.